Lesson 4. How to talk to the person and what not to say. Communicating with a person living with schizophrenia is one of the most challenging and at the same time one of the most crucial elements of caregiving. The way the caregiver speaks, the words they choose, the tone they use, and how they respond to the person's fears can significantly ease symptoms or, unintentionally, make them worse. In schizophrenia, a conversation is not just an exchange of sentences. It is a therapeutic tool that can bring calm, build trust, and prevent many crises. A person with schizophrenia experiences the world differently, more intensely, more chaotically, sometimes frighteningly. Words that are neutral for a healthy person can be perceived as judgment, pressure, threat, or rejection. The goal of this lesson is to show the caregiver how to speak in ways that do not hurt, do not provoke conflict, do not increase fear, and do not reinforce delusions. This does not mean the caregiver must be overly cautious or submissive. It means speaking with wisdom, awareness, and understanding that the person's neuropsychological state is altered. In this lesson, we will discuss principles of safe communication, ways to respond to delusions and hallucinations, tools for handling suspiciousness, and sentences that must be avoided at all costs. You will learn why it's impossible to convince with logic during psychosis, why pressure and confrontation almost always backfire, and how to speak so the person feels safe even if they disagree with your view of the situation. Communication is a bridge between two worlds. In schizophrenia, those worlds may be very far apart, but the right words can reduce that distance more effectively than medication. Why an ordinary conversation doesn't work. A conversation with someone who has schizophrenia follows different rules than a conversation between two healthy people. Not because the person refuses to listen, doesn't think logically, or causes trouble. The real reason is deeper. Their brain processes stimuli differently. Information, emotions, social signals, and tone of voice arrive distorted, sometimes too intensely, sometimes chaotically, sometimes colored by fear. A message that feels neutral and calm to you may be perceived by them as pressure, threat, or hostility. In stable periods, the person may converse almost normally. In periods of worsening symptoms, even simple statements may feel overwhelming. Words flow too fast, logical structure requires concentration. The person doesn't have any suggestion may evoke fear or resistance. This is not purposeful defiance, it is a symptom of the illness. The nervous system is overburdened and reacts with hypersensitivity. Ordinary conversation also fails because the person interprets the world through the lens of their fears. Healthy people filter information rationally, distinguishing facts, emotions, and guesses. In psychosis, this filter does not work. If the person is afraid, any word may feel threatening. If they're suspicious, any phrase may seem like a hidden message. If they're overstimulated, any remark may spark an emotional reaction. The content of the sentence matters less than how their brain receives it. In psychosis or the prodromal phase, the person's mind is occupied with something much stronger than the conversation: inattention, intrusive internal stimuli, fear, and feelings they cannot name. Attempts to reason, explain, debate, or appeal to logic act like pressure, and pressure increases fear. Even a highly rational person during remission cannot access rational thinking in an acute phase. That's why the caregiver has to change the way they talk. Instead of trying to work on the person's beliefs, they need to work on their emotions. Instead of offering logical counterarguments, they offer a sense of safety. Instead of asking questions that demand analysis, they ask short and simple ones. Instead of raising their voice, they lower it. Not because the person is being treated like a child, but because in that moment their nervous system is functioning differently than that of someone who is well. An ordinary conversation doesn't fail because the person doesn't want to understand it. It fails because they cannot understand it in the usual way. Once the caregiver really takes this in and adapts their communication style, the atmosphere becomes calmer, and the person becomes more open and less threatened. That creates the space for genuine contact, where words stop wounding and start helping. How to speak so the person feels safe. In schizophrenia, a sense of safety is the foundation of every conversation. The person does not really listen to what you are saying as long as their nervous system is in defensive mode. Only when they feel they are not under threat, that they will not be judged, criticized, mocked, or overpowered, do they open up to contact. This is why the way you speak often matters more than the exact content of your words. Above all, it helps to remember that tone of voice reaches the person more strongly than the words themselves. Your voice should be soft, calm, slow, and unhurried. When you speak too fast, the person can feel overwhelmed and respond with fear. When your intonation is too intense, it is registered as danger. Even in emotionally charged situations, it is worth consciously lowering your tone so that your message reaches them without triggering an alarm inside. Another key element of safety is using short, simple sentences. Complex, analytic statements demand a level of concentration the person often doesn't have. When you use simple sentences, they don't have to struggle to decode what you're saying. Their energy can go toward calming down rather than trying to untangle your words. A short sentence also gives them time to process what you've said. Pushing for a quick answer, correcting them, or pressing for more details only increases their defensive reaction. A third rule is to avoid judgment. The person reacts very strongly to even the slightest sign of disapproval. Even gentle criticism can, in their experience, grow into a sense of rejection. That's why it is so important to speak not about what they are doing wrong, but about what you observe and how you can help. Instead of "you're acting weird," you might say, "I've noticed you seem more tense lately. I'm here to support you." Instead of "you need to pull yourself together," you might say, "I can see this is a hard day. We can talk whenever you feel ready." Another crucial aspect is not getting into a direct conflict with the person's inner world. If they say someone is following them, answering "that's not true" will almost always cause them to shut down immediately. A much safer response is something neutral and containing, such as, "I understand this is very frightening for you. I don't see it, but I can stay with you." A reply like this doesn't confirm the delusion, but it also doesn't attack it. Most importantly, it doesn't inflame their fear. Physical space matters too. The person does not always tolerate closeness, especially in phases of heightened suspicion. If you step too close, you can unintentionally trigger a sense of danger. It is better to talk at a comfortable distance, ideally sitting down, with your hands visible and relaxed. Your face should be calm. Facial expressions are often taken very literally, so even a slight grimace can be read as hidden hostility. And finally, don't try to solve problems in the middle of a crisis. When the person is agitated, they cannot absorb explanations, instructions, or logical arguments. In those moments, there are only three real goals: to calm the emotions, to build a sense of safety, and to reassure them that they are not alone. I'm here with you. Let's breathe together. Nothing bad is happening right now. These simple lines are often more therapeutic than the finest medical lecture. Safe communication is not about hiding the truth or pretending everything is fine. It is about tuning into someone who, in their suffering, experiences the world in a more intense and chaotic way than others. It is this tuning in that allows the caregiver to become an anchor for the person rather than just one more stimulus overwhelming their mind. What not to say to the person? There are phrases that a healthy person will hear as a casual remark, while someone in a psychotic state may experience them as a blow. This isn't because the person is oversensitive, but because their nervous system is functioning like a badly tuned radio. Every emotional signal comes through amplified, mixed with fear, and interpreted far more literally. Certain statements can unintentionally worsen symptoms, provoke anger, sow mistrust, or lead to complete withdrawal. As a caregiver, you need to know what to avoid. The most harmful are statements that directly invalidate the person's experiences. Phrases such as "that's ridiculous," "you're making this up," "there's nothing there," or "to stop being silly" may sound like attempts to correct things logically, but the person hears them as attacks on themselves. If they say someone is watching them and you respond firmly, "that's not true," they take it as a sign that you don't understand them, that you don't respect their fear, and that you are trying to take away what little sense of safety they have. In their perception, those words don't bring them back to reality, they reinforce suspicion and anxiety. It is also important to avoid evaluative labels. Remarks like "you're weird," "you're overreacting," "you're causing problems," or "here we go again," even if spoken in frustration, tend to confirm their worst fears, that they are a burden, that they are not accepted, that they are letting their loved ones down. This deepens isolation and erodes trust, and trust in schizophrenia is the bedrock of any therapeutic relationship. Threats and emotional blackmail are equally dangerous. Lines such as "if you don't calm down, they'll lock you up in the hospital," or "if this goes on, I'll stop helping you," do not calm the person. They can trigger panic. The person interprets them literally, as real danger. The threat of hospitalization does not soothe them, it brings despair and rebellion. The threat of abandonment creates a sense of catastrophe. For someone already living in a world filled with fear, these sentences are like fresh wounds. It is also unhelpful to try to hurry them with phrases like "calm down right now," "I've had enough," "pull yourself together," or "stop acting like that." The person does not have control over how intense their symptoms are, just as someone having an asthma attack cannot just start breathing normally. Expectations of this kind only raise their tension and force them into an inner struggle they are already too exhausted to fight. One of the most common mistakes is trying to shake the person into clarity. Saying things like "think logically," "this makes no sense," "look how you're acting," or "stop whining," even if meant well, is completely ineffective in schizophrenia. In those moments, the person simply doesn't have access to logical thinking. Their mind is busy defending itself against internal chaos. Trying to reach their rational side is like shouting to someone who is underwater. Even if they hear a noise, they cannot understand it or follow directions. It is also not helpful to offer the kind of reassurance that minimizes their suffering, such as "other people have it worse," "you're overreacting," or "snap out of it." In everyday culture, these lines are sometimes seen as motivating, but to someone who is ill they sound like a denial of their pain. They do not need comparisons or ratings of how bad things are. They need one thing: for someone to acknowledge that their fear is real for them, even if it is not objectively real. Finally, it is important to avoid overly intense emotional reactions. When the caregiver starts shouting, crying, panicking, or becoming aggressive, the person often interprets it as proof that something really terrible is happening. The strong emotions of the caregiver are registered as danger signals, which immediately intensify symptoms. The most important thing is to keep your tone steady, calm, and predictable, even in difficult situations. Words can heal, but they can also wound more deeply than any action. This is why the caregiver has to learn a new language, a language of safety, empathy, understanding, and emotional neutrality. It is not about hiding the truth, it is about offering it in a way that will not become yet another source of fear. How to talk about medication, seeing a psychiatrist, and hospitalization. Talking about medication, psychiatric visits, and possible hospitalization is one of the biggest challenges a caregiver faces. For the person who is ill, these topics touch on their sense of freedom, control, and safety. Even someone in remission may feel anxious about being medicalized, and during a worsening of symptoms they may see these suggestions as a threat or an attempt to dominate them. This means that the way the caregiver approaches these conversations will largely determine whether the person is willing to cooperate or retreats into resistance. The most important thing is not to present treatment as something forced on them, but as a shared effort to keep things stable. Instead of saying, "You have to take your meds," it works much better to say, "I can see you're really tense. The meds will help you feel more steady." When you talk about seeing a psychiatrist, it's better to avoid phrases like, "You need to be checked," and say instead, "Let's talk to the doctor, they're the one who can best tell what will help you." The person needs to feel that decisions about treatment are being made for their sake, not against them. Your tone should be soft but firm, the tone of caring, not pressure. When you bring up seeing a psychiatrist, it helps to avoid giving the impression that this is a punishment or a last resort. In schizophrenia, follow-up visits are like regular medical checkups in any chronic illness. It's worth normalizing them. Anyone who's on medication should see their doctor from time to time. It's nothing unusual, just part of treatment. A person who doesn't feel judged is much more likely to agree to cooperate. Hospitalization is an even more delicate subject. In a psychotic episode, the person may experience a hospital stay as a threat, even when it is the only real way to help. In those situations, it is better to speak not about the facility, but about safety. "We can see how much you're suffering. In the hospital they'll be able to help you calm down faster, and I'll be there with you." Try to avoid words like "you have to," "you must," or "there's no choice." they tend to sound like an attack. Instead, use a language of care. I don't want you to be in so much pain. We can go there just for a few days, so everything can settle down. At the same time, it is important that the person does not feel nagged or attacked when the conversation turns to everyday responsibilities. In more stable periods, they should take part in daily life as much as their condition allows. But it is not helpful to bark orders in the form of commands: clean up, do this, get yourself together. A person with schizophrenia often hears that kind of language as pressure and pressure as danger. It is usually safer to invite cooperation. Let's do this together. I need help with this one thing. You can choose what you'd like to do today. Everyday tasks should not become a tool for judging the person. In schizophrenia, even a small task can be hard because mental energy is variable and concentration is impaired. If something doesn't get done, it should not automatically be read as laziness or bad will. It is much safer to ask, do you have the energy for this? What would help you today? Which task feels easier for you? This kind of approach strengthens their sense of agency and, at the same time, gives the caregiver a realistic picture of what the person can manage. It also helps to remember that conversations about responsibilities should always happen in calmer periods, not in moments of tension. When symptoms are flaring, the person is not able to absorb instructions or plan tasks. The same goes for talking about medication or psychiatry. Doing it in the middle of a crisis only ramps up fear. The best results come when the caregiver chooses a moment when the person is rested, has eaten, and is relatively stable emotionally. Both medication issues and daily responsibilities share the same core principle: the way you communicate shapes the whole reaction of the person who is ill. When the caregiver expresses care rather than control, cooperation rather than coercion, closeness rather than domination, the person feels safer and is less likely to respond with resistance. It isn't the number of words that heals, but the tone, intention, and space we offer another human being. Summary: communication with a person living with schizophrenia requires a different language, a different pace, and a different sensitivity than talking with someone who is well. This is not a matter of personality or being difficult, but a consequence of how the illness affects perception, emotions, and the interpretation of signals. A caregiver who understands this difference can create around the person an environment where fear goes down and a sense of safety grows. Only in that kind of space is genuine cooperation possible, and without cooperation, effective treatment does not exist. This lesson has shown that it is not the content of your words that builds or destroys connection, but the way they are spoken. Tone of voice, facial expression, pace, and sentence structure can either calm the person or stir them up. Avoiding confrontation, pressure, judgment, outright denial, and attempts to fix their experience with logic is a basic part of support. On the other hand, empathy, calmly acknowledging their emotions, short messages, and a neutral stance toward the content of delusions are tools that truly protect against conflict, panic, and relapse. Talking about treatment, medication, psychiatric visits, or hospitalization demands special gentleness because it touches the person's deepest fears. Only a language of care, not force, creates the space in which they can agree to accept help. In the same way, conversations about daily responsibilities cannot be built on demands and pressure, but on cooperation and a realistic view of what they can manage. In schizophrenia, even a small task can be a big effort, and the level of functioning can change from one day to the next. The most important message of this lesson is simple. Even if it takes practice, don't try to change the content of the person's inner world. Try to change how they feel. It is the emotions that are the doorway to contact, cooperation, and safety. And wherever there is safety, there is room for treatment.